Assalamu alaikum. Welcome to 10 Clinical Minutes. Our subject today will be hemangiomas, specifically infantile and congenital hemangiomas. Vascular anomalies are generally classified as either vascular tumors or malformations. But if the findings do not fall into one of these categories, it is classified as potentially unique vascular anomaly. Our subject today lies under the benign vascular tumors category. Infantile and congenital hemangiomas is defined as benign tumors of infancy due to endothelial cell proliferation. Infantile and congenital hemangiomas differ from each other, and this is important to recognize. Most infantile hemangiomas appear weeks to months after birth in almost 70% of patients. But there can be precursor lesions predicting the appearance of the hemangioma. On the other hand, congenital hemangiomas are very rare and are always fully developed at birth. Females are more prone to develop infantile hemangiomas, but there is no gender preference in congenital hemangiomas. Most infantile hemangiomas affect the head and neck, followed by the trunk and the extremities. In congenital hemangiomas, the extremities are the most affected sites. The number of infantile hemangiomas is usually solitary and localized, or multiple in 15% of cases, and segmental lesions may be present. In congenital hemangiomas, they are mostly solitary unilateral lesions. The pathogenesis of infantile hemangiomas is not fully understood. There are several theories, including placental tissue embolized to fetal tissue, the occurrence of hypoxia during pregnancy leading to upregulation of vascular endothelial growth factor, insulin-like growth factor, and GLUT1. Another theory is that there is upregulation of angiotensin II. Angiotensin II is already high during early infancy as a normal finding. The elevated angiotensin II may also upregulate vascular endothelial growth factor and osteoprotogerine. All these factors induced by hypoxia and angiotensin II lead to vasculogenesis and anti-apoptotic mechanisms. Because of the rarity of congenital hemangiomas, the pathogenesis is not yet known. Another difference is that the glucose transporter 1 protein is positive in infantile hemangiomas but negative in congenital ones. There is also differences in the course of the disease. For example, in infantile hemangiomas, we have 3 phases. The proliferative phase, which lasts 1 to 2 years, where the hemangioma increases in size, and then the involuting phase, which lasts between 5 to 10 years, and after that, the involuted phase, where in 50% of patients, the skin returns to normal, and in the rest of the patients, there is residual skin changes. In congenital hemangiomas, there is a proportional growth of the lesion, and we have 2 main types: the rich, rapidly involuting congenital hemangioma, which start involuting weeks after birth and is fully involuted around 2 years of age, and there is the non-involuting form that does not decrease in size by age. Both diseases carry the complication of cutaneous ulcerations. However, if infantile hemangioma is affecting internal organs like the heart or the respiratory system, there can be more serious complications. Infantile hemangiomas may be associated with Faces syndrome or lumbar syndrome. However, we are not sure if congenital hemangiomas is associated with syndromes because of the rarity of the cases and no dedicated studies to tell us. Infantile hemangiomas may present in one of 2 forms, either a superficial or a deep infantile hemangioma. The superficial form is characterized by a lobulated and bright red lesions with a very thin and delicate surface epithelium. The deep infantile hemangiomas, the epidermis retains its normal thickness and it is not thinned, and the overlying skin often has a bluish hue. As we discussed, congenital hemangiomas come in 2 forms. Either the rich, which is a raised violaceous tumor with ectatic veins surrounded by a pale rim of vasoconstriction, and the niche, where its round maximum diameter is 10 cm with a coarse overlying telangiectasia, and it's warm to palpation with a fast arterial flow. The most important differential diagnosis for infantile and congenital hemangiomas is the vascular malformations. Vascular malformations are like congenital hemangiomas, they must be present at birth. However, infantile hemangiomas, most cases, are not present at birth. The growth of infantile and congenital hemangiomas is variable according to the type and timing, as we discussed. Vascular malformations grow with the child. Hemangiomas are neoplastic, while vascular malformations are non-neoplastic. That's why in infantile and congenital hemangiomas, we see a proliferation of endothelial and vascular cells, but this is not evident in vascular malformations. In infantile and congenital hemangiomas, we see no coagulation abnormalities. However, this may happen in some vascular malformations. There is increased mast cell count in infantile and congenital hemangiomas, but this is not found in vascular malformations. Also, the glucose transporter 1 protein is positive in infantile hemangiomas, but negative in vascular malformations as well as congenital hemangiomas. Infantile and congenital hemangiomas should also be differentiated from other vascular tumors, whether benign like tufted angiomas, or locally aggressive like Kaposi-4 hemangioendothelioma, or even rarely like early malignant vascular tumors including angiosarcoma and Kaposi sarcoma. It is also of extreme importance to recognize associations of infantile hemangiomas, the most famous of which is the Faces syndrome and the lumbar syndrome. In Faces syndrome, we have posterior fossa brain malformations, large hemangiomas of the face, anomalies of the arteries, affection of the heart, the eye, and the sternum. In lumbar syndrome, in addition to segmental hemangiomas affecting the lower part of the body, we have urogenital abnormalities, spinal cord, bone abnormalities, malformations of anus and rectum, as well as renal abnormalities. Once recognized, these syndromes require a multidisciplinary approach to provide appropriate treatment. Thank you very much.